Hello, ladies and gentlemen. Welcome to Cardiology Lecture Series. I am Dr. NIK NIKAM. I have been a cardiologist at the Texas Medical Center for more than 30 years. Today, we are going to look at cardiac myocyte and sinus node action potential. This is the foundation for the electrical, the mechanical, the physiological, and hemodynamic effects of the pumping action of the heart long before we are born until the last heartbeat of our life. So let us look at how does an impulse arising from the sinus node travels through the AB node and through the Purkinje fibers and activate the myocardial cells, which leads to electrical activation of the heart as a all or none phenomenon, which leads to mechanical compression of the ventricular chambers with the expulsion of the blood into the pulmonary artery and into the aorta, thus maintaining continuous circulation for lifetime. This is an amazing electrical activity. And how does this happen? And this is explained by a simple process known as the action potential. Action potential is the starting point for all the electrical and mechanical activities of not only the pacemaker cells such as the sinus node, the AB node, the Purkinje fibers, and even the atrial and ventricular fibers. More importantly, the individual muscle cells, the myocytes. So first we are going to look at the cardiac myocyte action potential, and then we look at sinus node action potential and see what the differences are and how they translate into the functional aspects of the cardiac function, namely the pumping effect of the cardiac chambers. Most of you must be familiar with this action potential. If not, you need to imprint this image into your brain if you are an internist, a cardiologist, so that you fully understand how a myocardial cell responds to an electrical stimulus and then leads to mechanical contraction of the heart itself. This is known as the action potential. Action potential has four main phases. Phase 0 is the rapid depolarization wave, which is followed by phase 1, which is a slight repolarization, and that is followed by a plateau which sustains the depolarization phase, and that is followed by a gradual decline, which is the repolarization of the myocardial cell. I just wanted to let you know we are talking about what is happening inside the myocardial cells itself, and here is the intercellular space, and next to that is the next myocardium here. So how does this action potential happen to make both actin and myosin to contract so that we get shrinking of the myocyte, which collectively will lead to the left ventricular contraction? So this action potential returns to phase 4, which is the baseline. So this represents the depolarization of the heart muscle cell, and this is the stasis followed by repolarization, and then we have the equilibrium phase. So the next phase again begins here. This is a very simplistic depiction of the electrical activity happening inside the myocyte. Let's get a little deeper and see actually what is causing these electrical changes inside the cell and outside the cell, and what brings on these electrical changes. In order to explain as how this myocardial cell goes through this action potential which I just described to you, let's get back here for a second. And as I said, the electrical impulse begins at the sinus node. The electrical impulse begins at the sinus node, and this impulse is transmitted as an ionic current through the AB node into the Purkinje fibers, and it reaches the space between the cells, which is known as the gap. And through these gaps, there are connections to each individual myocardial cells, which sends this positive ionic current, which then stimulates the muscle here somewhere along the line, and then begins this action potential. Now let's look a little deeper into this action potential and see what happens. First of all, the cell itself, myocardial cell, and then we have the interstitial space here, then we have another myocardial cell bundle here. The voltage inside the myocardial cell is minus 90 millivolts, and when it reaches a threshold of just about 80 minus millivolts, suddenly there is exchange of ions, namely sodium, we have potassium, then we have calcium, then we have chloride. Mainly these four elements which are exchanged from the extracellular space into the myocardium. Some of them go outside the myocardium and some of them come inside the myocardium at different phases of the action potential to create this classic action potential graphic representation of the ionic exchanges happening at this cellular level in the interstitial space and inside the myocardium. Let's say we are getting an impulse from the sinus node into each one of these myocardial fibers. This electrical impulse or a positive ion triggers the myocyte, which increases the voltage from minus 90 to approximately minus 80. At that time, the rapid sodium gates are opened, which allows for the influx of sodium inside the cell, leading to a sudden change in polarity inside the cell, going from minus 90 to minus 80 to almost 25 positive millivolts. Pardon my handwriting because I'm doing it on a vertical screen here. When this happens, now we have the potassium channel open up, which pushes the potassium from inside the cell. Let's use a different color here. It pushes the potassium from inside the cell into the interstitial space. That causes a slight reduction in the voltage. That is followed by the third phase, which is the influx of calcium into the myocyte, and this is depicted here in green, which is the calcium channel. By the influx of calcium from the interstitial space into the myocyte, and eventually as the calcium enters the cell, there is sodium potassium ATP pump, which pushes the potassium from the cell outside, resulting in the membrane potential returning to the baseline. That's where we started off here on phase 4. So to recap, the intracellular space inside the myocyte is of minus 90 millivolts, and when it reaches through the stimulus coming from the sinus node or the AB node or any other higher site, the voltage increases by 10 to 20 millivolts, which then opens the sodium gates in these cell membranes, and that leads to the influx of sodium that causes sudden depolarization, which is represented by phase 0 of this action potential. Then we have phase 1, 2, 3, which are all related to the movement of ions, namely sodium, potassium, calcium, and chloride. The three most important ones are, of course, sodium, potassium, and calcium. This is, in a nutshell, summary of what happens inside the myocyte. We are talking about electron microscopic level at one myocardial fiber. And when this happens, there's activation of the protein inside the cells, the actin and myosin, which come together, glide into each other, causing the shrinkage of the myocyte, which eventually leads to contraction of the ventricle. Let's look further. And here I have depicted the same thing, except I want to mention that at the myocardial cell level, at least in the cardiac structure, when an impulse traverses through the sinus node into the AB node, through the Purkinje system into individual myocardial cells, it is going to go through what is known as the all or none phenomenon. That means when an impulse goes through, the entire heart muscle contracts, either the ventricle or the atrium at any given time, they contract. Whereas skeletal muscle, you can individually stimulate each finger muscle based on your control. Whereas with the heart, once you send an impulse, both the atria contract at the same time, and similarly both the ventricles go through this active depolarization and repolarization at the same time, so they contract mechanically at the same time. There are some important elements that we need to be aware of with reference to the action potential. Now let's say we have started off with an action potential here, and it is going to phase 0, where there is rapid sudden influx of sodium inside the myocyte. Can a second impulse come and disrupt this action, or maybe even make the action more exaggerated? The answer is no, because from phase 0 to the beginning of phase 3, we have what is known as the absolute refractory period. That means here, no matter how strong the electrical current is, it cannot change the electrical ionic exchange that is going on at the cell membrane level and its effect on the sarcoplasma, actin and myosin. As a result, this is absolute refractory period. That means no impulse can change the course of events during this particular cycle phase. Now, from the middle of the downslope 3 to the end of downslope 3, we have what is called the relative refractory period. This is where a little bit stronger impulse may be able to create a new action potential, but generally speaking, a weaker impulse may not be able to do so. At the end of phase and on phase 4, that is the excitation period, where any type of impulse, even if it is minor, can initiate an action potential, which is the one which is depicted here. So that is something we need to be very familiar with. This may be an important question for any test you might be taking. They are going to ask you, what is absolute refractory period? Absolute refractory period and relative refractory periods, and what phase of the action potential do they fall, or what phase of the cardiac cycle do they represent? This is an important concept to understand. So let's go a little further and look at the action potential in the myocyte compared to action potential spontaneous rhythmic site such as the sinus node, AB node, Purkinje fibers, or even myocardial cells as such. As you can see, we have a resting membrane potential which remains constant in a myocyte during a resting phase until it gets an electrical impulse or the ionic charge, which tells it to open the sodium gates that results in an action potential. Whereas in a sinus node or any pacemaker cell, the action potential varies a little bit. As you can see, we don't have a flat resting phase. During the resting phase, there is a gradual increase in the voltage in a pacemaker cell. Also, the resting voltage is minus 60 millivolts in a pacemaker cell as compared to minus 90 in a myocyte. Also note that it takes about 10 to 20 millivolts for this to start an action potential. And also an important thing is the slow uprise of this action potential is due to the influx of sodium into the pacemaker cells that increases the voltage gradually until you reach a threshold of minus 40 millivolts when there is a fast calcium channel influx. The fast depolarization phase in a myocyte is by sodium pump, whereas in a pacemaker it is a calcium pump. There is sudden influx of calcium which leads to the action potential, and we don't see that plateau in the sinus node or the pacemaker action potentials as we see here in a myocyte under normal circumstances. And again, this is followed by a fast potassium outflow pump, whereas here it is followed by a calcium channel and also by potassium channels. We have calcium and potassium, and here is basically calcium. Here it is basically a potassium outflow from the sinus node cells, and this repeats itself. Another important thing that we must remember is this action potential duration, which corresponds to the systolic phase of the ventricle or the systolic phase of the atrium, is very, very short. It's of maybe 300 milliseconds. If your heart is going at a rate of 60 beats per minute, you have 1000 milliseconds, of which your systolic phase is roughly 300 milliseconds. That leaves the diastolic phase at approximately 700 milliseconds. How does the heart rate increase? What happens to the action potential? Usually the systolic phase or the depolarization phase of the action potential is more or less fixed to a large extent. It is the diastolic phase that is shortened during a tachycardia. Let's say you have a sinus node impulse coming right along, and all of a sudden you give atropine. When you give atropine, it reduces the vagal stimulation of the heart. As a result, basically it is going to shorten the duration of your diastolic phase from 700, and that is why you are able to bring the next sinus node impulse much faster, something like this. As a result, you can basically double the heart rate in a matter of minutes. So this action potential is not only at the ionic level, where exchange of sodium, potassium and calcium happening at the cell membrane level, at the microscopic levels, but they all have perfect coordination so that they happen almost like a symphony orchestra that leads to a smooth mechanical, physiological and hemodynamic changes throughout the body. Let's see how we can put all these things together and in a real clinical setup and see if it makes sense. Here, let's start off with the sinus node. With a upsloping baseline, we have sinus activation action potential which traverses and it reaches the atrium. It produces an action potential in the atrium which leads to atrial electrical activity, which is represented by the P waves, and this leads to the activation of the AB node, which causes this AB delay, and that is followed by the ventricular activation, which is represented by the QRS complex, and here we have the ventricles, and these ventricles are represented by the QRS complex, and followed by there is repolarization, which is represented by the T wave here, and this is in a sense going from the microscopic ionic exchange levels into the surface electrocardiogram. And you know what happens with the surface electrocardiogram. You see these electrical changes, but inside the heart there's a lot more happening than just simple peripheral electrical changes that is reflected in our everyday 12-lead electrocardiogram. A P wave is followed by the atrial contraction, and after that this is by the P wave. Then we have the AB delay here. Then the ventricular contractions represent the QRS complex, and the relaxation is represented by T waves. So this is followed by contraction of the ventricles, pumping of the blood through the aorta and into the pulmonary arteries, into both the systemic and pulmonary circulation. So ladies and gentlemen, oh, there is a typo here, sorry, should have been myocyte. So this is an overview of action potential. We started off with the basic concept of how the impulse begins in the sinus node, and then it traverses through the Purkinje system into the myocardial cells, what an action potential looks like, and how this action potential is propagated through the myocardial structures, through the nodes, Purkinje fibers, interstitial fibers or tissues, and eventually leading to the contraction of the heart muscle. And knowing the differences between the action potential in a myocyte as compared to a pacemaker cell such as sinus node or the AB node, to eventually putting them all together into how an ionic exchange at the action potential level translates into the surface electrocardiogram and eventually into mechanical contraction of the heart, leading to hemodynamic changes that is resulting in cardiac output. Ladies and gentlemen, I hope this cardiac myocyte and sinus node action potential lecture has been useful to you. Thank you so much for watching, and please do subscribe to our YouTube channel, and we will see you next time. Thank you.